Welcome to this special edition of CareTalk, your home for incisive debate about healthcare business and policy. We are now at the 2020 emids Healthcare Summit. I'm John Driscoll, the CEO of CareCentrix, and today I have the privilege of having an intense conversation with Dr. Alan Lotvin, EVP of CVS Health and President of CVS Caremark, and more important, cardiologist, an adventure junkie, and an innovator. And we're going to get into what he's doing at CVS, what he is doing as an inventor, and how he, through CVS Caremark, is transforming care. Welcome, Alan.
Hi, John. Nice to be here. Thank you.
Alan, you've done a lot of interesting things at CVS Caremark and Aetna. We're going to get into them, but I think one of the most interesting for me is the big investment of time, effort you've made into CVS Kidney Care. And certainly one of the most frustrating things for me has been, at CareCentrix, we focus on care to the home, why there isn't more dialysis at home and why we haven't innovated in kidney care. Can you tell me a little bit about how you folks look at that problem and that opportunity and kind of what you're doing to change it?
Yeah, no, that's a great question. It's one I love talking about, right? It's one of my I hope one of my lasting legacies. So we got into kidney disease because as I've gone around and talked to all sorts of different payers over the last, decade and a half of my career, many times people would say whatever I was talking about was all well and good, but please, can you help me with dialysis, because I don't have great options. The outcomes are terrible and it costs a lot of money. And so I didn't really have solutions. And through the course of a bunch of other different projects, I met an absolutely fascinating person, arguably one of the most interesting people I've ever met, president company excluded, named Dean Kamen. And Dean was an inventor of a radically different home hemodialysis device, and was looking for partners who could help him commercialize it, bring it to market. And as we stepped back and thought about it, the way this machine is organized and architected, essentially, we would need to take care of complex people in the home, deliver a certain amount of supplies on a reasonably regular basis, and be able to stay in close touch with them. And generalizing kind of what I've been good at in my career running specialty pharmacies, it's that, right? We take care of relatively sick people in their home, dealing with them on a monthly or more frequent basis, and keeping very close tabs on them. And so we felt like it was a reasonable kind of fit for the organization. We felt that the relationships we had with payers would help accelerate the commercialization. So we set about finishing the development work with Dean. We're currently in our executing a clinical trial to achieve FDA clearance for the device. And once we've gotten that, we think this will be an important tool for people to reach those goals that have been recently set out of getting 40-50% of people at home on dialysis safely.
And just to kind of put this in context, I mean, I think kidney care costs Medicare north of $35 or $40 billion a year. That in the rest of the world, something like 20 to 70% of dialysis is done in the home. And what about the US? I mean, what are our statistics like in terms of home dialysis?
Yeah, so in terms of home dialysis, there's a couple of things in there. So one, we are at about 11 or 12%. And of that 11 or 12%, the vast majority, call it, all but 1 to 200 basis points is peritoneal dialysis versus hemodialysis. And peritoneal dialysis is fine. It tends not to be not the longest lifetime solution. So a lot of those people go on to hemodialysis. So as you said, in the best centers in the world, but also in parts of the United States, having 40-50% of people on home dialysis, many of them on home hemodialysis, is common. And when you get people on home hemodialysis 4 or 5 times a week versus the 3 times a week in center, just that more complete, clearance of all of the, accumulated toxins in your body essentially normalizes, plus or minus, the mortality and morbidity. And it's versus, called a 20% mortality. It's literally life-saving for people. And it's also, on top of life-saving, it's quality of life preserving, because if you're doing in-center dialysis, you're spending 3 to 4 hours a week, 3 times a week in a center. You got to get there, you got to get back and forth. You tend not to feel great right afterwards. So when people are doing it at home in the evening or overnight 4 or 5 times, they just feel better, and they're able to maintain their jobs and maintain their quality of life. I've met a bunch of people around the world actually on home hemodialysis who you would never know were sick. They're starting businesses. They're coaches. They're parents. It's really fantastic. I'll tell you one other statistic, which is if you go to one of the centers in Toronto, um, on the wall of the nurses station is a wall of baby pictures. That may not sound that unusual in a nurses station. However, it's all baby pictures of women who conceived and delivered full-term babies on home hemodialysis. And it is nearly impossible to carry a child to term on center dialysis. It's just not, there's just not enough, you can't do it. So that to me tells you the need for these sorts of things in the world.
Now, what is it about the innovation that CVS and you and I mean, Dean is one of the great U.S. inventors of our generation, probably the premier one. He's as productive and prolific as Thomas Edison, with a lot more commercial applicability in real time. And he's known for the Segway, but he's got all kinds of medical and device work that's pretty remarkable. But what is it about what you are going to do that's going to help make home dialysis more of a reality for those long-suffering American patients?
Yeah, so it's a great question, and given that we're in a clinical trial, I'm going to use what may sound a little bit like hedging words, because I just don't want to overpromise, right? So there are a couple of things. So starting from the beginning, this device was designed from the ground up to be used by patients in their home safely. So the entire interface for the patient is simplified. There's no essentially, you don't have to run tubes and run wires and worry about valves and connect bags. It's all self-contained and integrated. The patient has very little to do. In fact, getting the machine ready for dialysis is a 5 or 6 step process, of which the first step is open the doors. Then as it brings itself up to temperature, getting actually onto dialysis is another, I don't know, 8 or 9 steps, of which at least 3 or 4 are confirmatory. And the machine walks you through it. It doesn't let you do something that would be dangerous. So that's one very important, just the user interface. There are some safety features designed into it to protect patients who might be at home from needle dislodgement. That's one of the things people worry about. And so this machine has features that are designed to essentially turn the machine off within milliseconds if there's an issue, and it doesn't rely on kind of external separate steps. It's all integrated. And then last and probably most importantly, we don't talk about it enough, I think, when we think about this, is the dialysis machine itself is mated to a device that makes sterile water in prodigious quantities. So often the limiting factor in home hemodialysis is having enough water to literally flush all the toxins out, and by making extremely high quality water in just enormous quantities, we can provide flow rates that are equivalent to what you would find in a large in-center machine. So it's a combination of user interface, designed for safety, and a different water system that we think addresses most, if not all, of the issues that we were identified as barriers and hurdles.
So it's a better experience for the patient. Is it cheaper for the system?
I'm going to answer that in a couple of different ways. So you mentioned that there's $35 billion of spend in Medicare for dialysis. That's the direct cost of dialysis. If you look at the other associated healthcare costs from those patients, it's $100 billion plus. So it's the number one line item on the Medicare budget. If you talk to the people at the VA, it's their number one item also. So first and foremost, by giving people uh, more complete dialysis more frequently at home, the medical literature, and again, we'll over time add to this, the medical literature would say you reduce hospitalizations, you reduce need for additional drugs, and probably reduce total healthcare costs by 15 to 20%. As you think about the actual cost of delivering dialysis, one of the big costs right now is the fixed infrastructure of labor and sites that cause costs. So if you're at home, right, you're doing it yourself, you're in your own house. We don't need that infrastructure. So, at the end of the day, you have this really, I found it to be an incredible opportunity to create substantially better clinical outcomes, to lower costs for particularly commercial payers, right? And to really accelerate an innovative solution to get more care for more people at home. Now, when we started this 2 or 3 years ago, certainly didn't foresee a global pandemic, but taking really sick people who are at high risk, clustering them together on a frequent basis in any institution, whether it's a skilled nursing facility, a hospital, or a dialysis center, and then having staff go between them is not really where you want to be in a pandemic. So,
But just this is a really big idea. Around 1 in 7 adults in the U.S. have have chronic kidney disease. This is really exciting. But that we brought up the pandemic, the ever-present pandemic. How do you think that's going to transform? I mean, obviously at CareCentrix, we've seen a lot more interest in more care to the home, a lot more of a need for what we're doing in terms of care traffic control, being an advocate and a support, and really, as Paul Farmer talks about, accompanying the patient around their journey. How do you think that COVID is going to transform the way we get healthcare going forward? Because it's got to have long-term effects.
no, I couldn't agree more. And I think the longer it goes on, the more durable those changes are, right? I think we're going to see in American cities, we'll start looking, as we get back to quote unquote normal, we'll start looking like many Asian cities where a good chunk of people will be wearing masks all the time when they're outside. And I think just this has really changed so much about the way we consume so many different things. And so I think there'll be durable changes. I think one of those durable changes will be in the delivery of healthcare. And as we think about it, bringing more services, more clinical capabilities into people's local communities. And I define community broadly as kind of in their home, digitally on their devices, or in a retail setting, bringing care to people rather than having people have to go somewhere to get care sort of feels like it's something that we're going to see more and more and more of. This could be the moment where we really flip over to much more virtual care. And I think it's going to require, obviously changes in some regulatory environments. It's going to require some new thinking about healthcare services, some new thinking about technologies. I mean, how do we use technology? Because to some extent, a lot of the things that you would do in a physician's office are becoming feasible to do remotely using technology. One example would be if you went to a dermatologist and they use a special camera and light to look at your moles. There's a number of companies that have, and those devices, if you were a dermatologist, were very expensive, in the high hundreds to $1,000. There are now devices that you can clip to your phone that have equal optics and obviously much cheaper. And then they're paired to, artificial intelligence diagnostics, much like the retinal cameras. So I think those sorts of things are going to both change the experience and change the cost of delivering these services.
What we're seeing as well, Alan, is a real need for personal care, nursing. We're seeing a shift and an interest in leveraging other care navigators and care delivery support around sort of an integrated approach to patients, which in some ways is easier to do when you're delivering stuff in the home. But I think what is going to make it really powerful is the ability to digitize and simplify a lot of what doctors had to get access to, via an office visit. Because I think done correctly, and it's interesting to get your perspective as a cardiologist, it really creates a lot more leverage for doctors than they've had before, as opposed to, again, sort of if you think about any number of types of chronic care management, delivering it, monitoring it in the home, does with folks with sort of playing at the top of their license, really gives doctors an ability to get a lot more leverage. Do you think we're going to see that anytime soon?
Yeah, no, I think, John, you said something really important, which is get doctors to practice at the top of their license. I think we should get all health professionals practicing at the top of their license. We know that there are going to be physician shortages. We know it's hard now in many parts of the country to get doctor's appointments ex-COVID, right? So I think if we get to a point where the things that you need doctors and full medical training to do, that's where we should have doctors working on, right? You don't need a physician to titrate someone's statin dose, right? That can be done very well algorithmically by nurse practitioners. I personally think by pharmacists. In collaborative practice agreements, you can, and as we get to, again, lower and lower cost of stuff, it becomes easy to have point of care machines all throughout the communities where people can, get their cholesterol tested, share it in an appropriately private manner with the patient's control, and have either an algorithm overseen by clinicians or a clinician, titrate the dose without ever having to see a doctor again. It's not just about the doctor's time. It's also about the patient's experience. And if I could take 20 seconds, we see millions of people in Minute Clinic, and about half of the people we see in Minute Clinic don't have primary care doctors. We refer 3.4 million people or more a year to primary care doctors. It turns out that about half of those people actually don't want a primary care doctor. And you would say, why not? And I don't have a great answer. I haven't done a lot of research, but I'm just talking to people. It's like, if I want to go to Minute Clinic, I know I'm going to drive 3 to 5 miles or 6 miles because I can look on the website and see exactly where it is. I know exactly how long the wait time is going to be because we put it online. I know exactly what the cost is going to be because we used to paint it on the walls. Now we put it on a TV screen on the walls. And I know the visit's going to be 20 minutes because it's a consistent experience. Contrast that with going to the doctor. And again, I'm a cardiologist. I'm not trying to throw doctors under the bus. You're probably going to have to drive 15 to 20 miles. You don't know how long you're going to be in the waiting room. You don't know how long the visit's going to take, and you don't know how much it's going to cost. That uncertainty is unsettling for a lot of people. And so it's not an experience that I would consider a kind of modern commercial experience. So I think we need to help healthcare not just get better, cheaper, and faster with better outcomes. We also need to have it start to approximate the expectations that people have around the experience and the ease of use and the simplicity of scheduling and all those sorts of things that we take for granted in most other parts of our life.
Well, but if you, and I think, Alan, COVID is going to be a forcing function, not just for telehealth. What we're seeing at CareCentrix is a lot more interest in doctors leveraging nurses and LPNs and folks who can go to the home, a lot more flexibility and openness to technology. If we can monitor more information, if we can share more information. What's remarkable to us is as centered as the system has been around hospitals and doctors' offices or SNFs, there really is no visibility to what happens to patients. And I think that you're absolutely right. Healthcare is about the most inconvenient, non-consumer friendly system we could have developed. And I'm hoping that COVID will be a forcing function for innovation that's in the patient's best interest, and that actually ends up helping doctors do their jobs and to your point, do the jobs that they were really trained for, as opposed to the administrivia or clutter that often kind of clutter, sort of fills their day. But I just pray that COVID, that the innovations that work in COVID, are sustainable. Maybe we talk a little bit, Alan, about how you're thinking about it Caremark, obviously we're focusing on innovation in this episode, but we all need to have some solutions to this pandemic. The vaccine is sort of the cavalry. Everyone's our fearless leader is suggesting it's right around the corner, but the challenges are huge, and we need to wrap relatively quickly. But you represent with CVS Caremark one of the biggest chunks of the supply chain and delivery chain of this. What's your level of confidence that we're ready if the vaccine is ready, 6 months from now?
Yeah, so I'm pretty confident. I'm confident in a couple of reasons. One is, we've been working with all the appropriate authorities to ensure that we have the right, that for example, pharmacy technicians can administer the vaccine. We've been working to understand how to best support the unique cold chain requirements of all the different vaccines. Thinking through the information technology and information needs of tracking patients, scheduling appropriately so that you get the booster when it's needed, and make sure you get the right booster. So all those things are things that we've been actively working on with other stakeholders in the supply chain to ensure that when vaccines are available with the appropriate stratification of need, right? Because we want to be sure that the highest risk patients and first responders and people in hospitals and doctors' offices are getting those vaccines quickly. That will be prepared to support the needs of the country. And again, there's nothing inherently different about what we would do for vaccines than what we do every day. I mean, there are nuances that are different, but you're not building something from scratch.
With all of the uncertainty around therapeutics and vaccines, you believe the supply chain and the delivery system we've got can handle it?
I believe that we will, when we get there, we will be in good shape to handle it, much as we've been able to deal with the incredible volume of testing.
Alan, I would argue that perhaps I'm hoping for better on vaccines than testing, and I think you've made a good case for that. With that, I think I want to wrap this, and I really thank you for this fascinating and wonky but really relevant conversation. It's given us reasons to be confident that in this very uncertain time, we're going to have a path to vaccinate the country. So thanks, Alan.
John, my pleasure, and really good questions and a great conversation, and we'll look forward to continuing it.